All right, we may begin. Over to you, Emily.
Oh yeah, thank you so much, Adauda. I think, I don't know whether you can hear me, everyone. Am I audible?
Yes, I can hear you.
All right, good afternoon from Nairobi. Good morning, good evening, wherever you're all joining us from. My name is Emily Chebet. I'm a journalist, an environmental health and science journalist in Kenya, Citizen TV. And I'm glad to be the one who is hosting this webinar this afternoon. Actually, it's 2 p.m. Kenyan time. And thank you so much for everyone who's gotten time to join us. It is a last part series. It's a fifth, actually. We've had like 4 of them. This is the 5th one, the last series that is hosted by a health tech platform by Affidep. So this afternoon, I just want to welcome every one of you. And I'm glad that I've seen all the panelists here. And I think it's time for us to kick off. It's about, of course, the ending malaria in Africa. And it's wonderful to see all our panelists today, which are rich in content. And I know we are going to learn quite a lot this afternoon. So today is just that day that we want to talk about the ending malaria in Africa. And we will start this platform by just giving a chance to our keynote speaker, who will give us, will take 20 minutes actually, to give us everything that concerning this. And our keynote speaker this afternoon is none other than Faith Osier. She is a trained pediatrician in Kenya, specialized in immunology, and obtained a PhD from the Open University in the UK. She's also a chair in, you'll excuse me a bit, people, I have a little of cold, but I'm sure we're going to catch up. So tonight, this afternoon here, Professor Faith Osier, the coordinator, Institute of Infectious at Imperial College in London, is going to give us our keynotes address, and then we kick off our webinar. Welcome. Again, I will give everyone to introduce themselves, I think just immediately after our keynote speaker, and then we go with the questions. And everybody, I am sure you'll be able to get something from all of us, and we're going to learn a lot this afternoon. Professor Faith, you're welcome.
Thank you so much, Emily. And thank you for hosting me, Affidep, for hosting me. It's a pleasure to have this discussion today. Just going to share my screen and go to full slide. Emily, can you see my screen okay?
Yes, Prof.
Okay.
Making malaria history. Yes.
Yeah. Thank you. Yeah. So we're thinking about eliminating malaria, and I just want to share my perspectives, which take into account about 20 years of working in malaria, beginning as a junior doctor in Kenya, trained at the University of Nairobi. Wasn't really that aware of malaria until I became an intern, and I did my internship at what was then Coast General Hospital. And then I saw a few cases of severe malaria, but malaria didn't really hit me until I went post-internship to work in what is now Kilifi County Hospital. And then that's when the reality of what malaria hit me. So although I had grown up until that point, maybe I was 25, 26, I hadn't really encountered malaria in any significant way that had an impact on me. But once I got to Kilifi, and as a junior doctor on the ward and admitting patients night after night after night, that's when it really hit me that we have a problem with malaria, And I think that's why this initiative is so important, that we increase awareness, because even within the country, I think there's a level of not being aware for reasons that we're going to discuss. And so for today, I mean, the webinar series has been going on about how we end malaria in Africa. And its aims are really to create awareness, which is what we're doing today. Have a think about what's going on around malaria control, around malaria funding. Think about concrete actions that countries can take. And the focus really of today's meeting is the role of research and development. And that's what I'm going to try and talk about, just with this context in mind. And so I just want us to reflect. I just have a few slides really. And to be honest, these are to set the frame for a discussion and for engagement. This is from the World Malaria Report. We hear the numbers. So in Africa, we're really talking about Plasmodium falciparum malaria, although there are other species. This is the most important for us. Over 200 million cases in 2021, over 600,000 deaths. And those numbers, they are numbers, but behind every number, there is a family, there is a story, there is a child, there is a life, there is a community. And so it's really, I think, important, if you don't encounter malaria in your day-to-day business, in whatever you do on a day-to-day business, to just reflect that malaria has a major impact on homes. Malaria can lead to lifelong disability. You can imagine as a parent having a child that's normal, that's developing, that's growing, and then they get this infection, and then you have a disability that is lifelong, that impacts their future, that impacts their ability to earn an income, to contribute to society, that puts a big strain on the financial situation of the family. So big socioeconomic impact. And so as we think about increasing awareness about malaria, I just would like us to remember that this boils down to a home, to a child, and it has a big impact, and it impacts them for life. You may die, which is a major impact when you lose a member of your family, but for survivors, there's trauma, but there's also just the disability caused by malaria. And I think that when we talk about the numbers, it's easy to forget that there are real people behind those numbers. And I'd just like to reflect on that for a moment. And that malaria is really a disease of the poor. And it perpetuates a vicious cycle of poverty because of illness and disease that then limits people's ability to earn an income and to be productive. And it just goes round and round in a vicious cycle of poverty that is difficult to break from. The second point I'd like to make, just using the same map, is that the intensity of malaria is variable. So I gave my example of growing up in Nairobi, where actually I hadn't experienced any significant amount of malaria until I was a junior doctor. And it's what you see on this map is really that malaria is patchy. The areas where it's blue, malaria is less intense. The areas where it's red, it's very intense, and then yellow is sort of in between. So even within our country, Kenya, there's a lot of malaria in Western Kenya. There's a lot of malaria in the coastal areas of Kenya. But if you are in Nairobi or in the highlands or in certain parts, you might not experience malaria. And that's true across the country, the continent, that really the burden of malaria is variable. It depends whether you're in the city, whether you're in the villages. Your socioeconomic status is important because it determines where you live, how you're able to protect yourself from malaria. And so while we think about eradicating malaria, you'll have discussed this in all the previous sessions, that there isn't one shoe size that we can say, okay, go out and do this, and now you're going to fix the problem. There isn't really a one shoe size that fits all. And that as we think in this webinar continentally, it's also important to think locally. And that really goes down to the grassroots level, to what people are experiencing for malaria on the ground. So what are the opportunities that we have to intervene? So I put a boring life cycle there for those of you who don't like to look at these kind of things. But just to make 2 points really, that one, the disease is complex. If it wasn't complex, we wouldn't be here still discussing how to solve it so many years after it was discovered. So it's a complex disease. It's got a complex life cycle, which I'm trying to demonstrate in this picture here. But the opportunities to intervene at different points of that life cycle. And because I'm an immunologist, I focus more on the human. That's why it's got the bigger picture. But there are others on the panel, like Professor Mbogo, who focuses on the vector, on the mosquito. And I'm sure if he was showing a slide, he would show you all the complicated steps within the mosquito. So there are complicated steps within the mosquito. There are complicated steps within the human. And in thinking about malaria control, we have to think about these two. We can think about the mosquito, we can think about the human, but we also think about the environment in which these two cohabit, and these are the potential areas where we can intervene against malaria. So if you ask yourself, okay, Faith, so where exactly in the community is malaria? You know, I told you that I grew up in Nairobi. I didn't see much malaria. So where is it? This graph is taken from Kilifi at the coast of Kenya, and it shows where the burden of malaria in the community. So at the bottom of the graph is the x-axis, and that's age. And on the y-axis is a frequency. And what you see in the green line represents severe malaria. And what this graph is telling us is that in young children under the age of 5, let me see if I can get my pointer to work. Yeah, I don't know if you can see my pointer, but in any case, in young children under the age of 5, which is what is shown by the green line there, that malaria is very common. The frequency of that is very high, but it really drops down rapidly. And by the time children are 10, you don't see the severe malaria that kills children. Yeah, so this is severe malaria. This is what has people in intensive care or high dependency units needing extra support. This is the malaria that's life-threatening, that kills you. So when you look in the community, who's got this malaria? Who's getting this kind of malaria? What you find in areas where malaria transmission is intense, as it was in Kilifi when this data was collected, is that that burden is high in very young children, but it rapidly drops off. So if I asked you, where is the malaria in the community, then one of the first answers would be, well, it's in the very young children where it's very dangerous and it can kill them. If you look back to that graph, there's another line, which is the blue line, and that line is for uncomplicated malaria. So this is the malaria where you feel like you have the flu. You have a headache, stomachache, you feel malaise, you've got a fever, runny tummy, whatever, but your symptoms are not severe. You're not going to go into coma. Usually with treatment, you can be treated as an outpatient and go back home, take your meds and get better. So we call that uncomplicated or mild malaria. And again, if you look, where is this in the community? Who's got that? And you look at the age distribution, what you find again is that that's pretty common in the young children. And here going on up to the age of 10. But by the time people are teenagers, the frequency of uncomplicated malaria is already dropping. And by the time they are young adults, they're not actually getting episodes of malaria. So if you're looking for it, then this is the age group to look at. From the young until people are early adults, that's where you're gonna find that malaria. But then there's one more type of malaria, and that's what's shown in pink. And this is what we call in our scientific language, asymptomatic malaria, i.e., you've got the infection, but you don't have any symptoms. And so I've labeled that here as silent infections. So what's happening? These are people actually from childhood all the way to adulthood who are carrying parasites in their blood, but they're not becoming sick at all. So they're going to school, they're going to their farm, they're doing their normal everyday business. They've got the parasite in them, but they're not showing any clinical symptoms. And this starts all the way in childhood, and it persists in adulthood. And so what this means is that malaria is there actually in the whole community. And if you think about when we try to control malaria, we often target the young because they're the ones who are most at risk. They're the ones that are gonna die. They're the ones in whom the disease is so severe. So we'll come here and say, hey, I've got a new vaccine. I'm gonna give it to the under 5s. So that's good. Let's say your vaccine works very well. You'll protect the under 5s. But what happens when they get older? Yeah, have you just moved the burden of the disease to when they're older? There's transmission that continues from the older children to the younger children, from the adults to the younger children. So as you come in with your intervention, whilst you might target one group, if you don't think about the other groups, actually your intervention will work for a period, but transmission will continue because all these groups have malaria. And so as we think about malaria control and elimination, we have to think about the whole population. Targeted interventions have a role to play, but in fact, if we're really going to eliminate malaria, then we've got to think about what I can call a reservoir, and where transmission is going to continue coming out from. So I think it's an important consideration for our discussion today. And so the other point I want to make is, our toolbox. It's a multidisciplinary toolbox, and I think there's no other way. Right now, we've got vectors, and I've just used a bed net as an illustration of one approach to vector management. And I'm glad there's a vector biologist who can tell us more. There's so much more within just the sector of managing vectors. Within the area of drugs, this is really important. If you have a drug that's not working, that's only partially effective, if you have fake drugs circulating in the community, if the parasite is developing resistance to drugs, within drugs, there's a whole big body of work that, again, 20 minutes is not enough for me to do any justice to. And I just put it there as a flag that, yes, drugs are really an important part of what we are doing as a global community for malaria control. Rapidly acting drugs, combining drugs to delay resistance. There's just a lot within drugs. Again, with diagnostics, these are improvements to how we diagnose malaria. Again, it's important because if you don't know what you're treating, then you don't know what you're treating. You don't know whether the child is improving because you're treating malaria or because you're treating something else. And you don't know how much malaria you've got if you don't actually measure it with a tool that's appropriate and generate data that you can trust. So in terms of tracking our progress and in terms of managing the condition, then we really need to know where we are and we need to have the tools to be able to measure. So again, a huge body of work is under the topic of diagnostics that I can't do justice to. And I mean, the place that I am particularly interested in is vaccines. And I think that vaccines have huge potential. But we have some vaccines. I said but first. I think it's exciting that we have vaccines. But if you reflect back to what I told you, Our vaccines, we have to really begin to think about the whole community. Yes, we can target the under 5s, and that's great. But if we're going for elimination, then we've got to get rid of every last parasite in every last person. And the vaccines that we have at the moment, there are multiple challenges. There are challenges of efficacy. There are challenges of how long does it protect you from. Malaria comes around every year. In some parts of Africa, it's present all year round. And so we still have those challenges to overcome. And so I put those as sort of the headline tools, but underneath those are others that perhaps we won't have enough time to discuss that are equally important, that none of the fancy things we can come up with in R&D can actually work if we don't have health systems in which to deliver them, if we don't have good implementation science that shows us how to get things to people, how to deal with issues of access, how to deal with acceptability. Sometimes we think we've got such cool inventions, but are these inventions, are people going to take them up? We have to think about cost effectiveness. What's it going to cost? Is that the best way to spend a limited resource of finance? We have to think about sustainability. Malaria transmission continues. So can that bed net last a lifetime? Who's going to pay for the next one, for example? We've got to think about policy. How is R&D taken up in the country? And lastly, I want to just mention poverty. As I said in the beginning, without facing poverty and lifting up the socioeconomic status of our people, I think then, we're still going to be battling malaria. And so I don't think this is a comprehensive list, but I think I put out what came to me immediately as a way to just bring the discussion on, if we're really gonna eliminate malaria, then there's really a complex interplay of factors that we're going to have to look at. And so what can we do about it? So I just have, again, a few slides, and this is really one of my favorite slides, photographs taken in Kemri Kilifi. And I just think it's so important in passing the message that we must empower the local workforce. I think that solutions are going to come bottom up from people who are on the ground, and from people who can innovate. And I think there's no shortcut to it. There's no escaping it, that we've got to engage the youth, and that this is the generation that has the innovations that are going to take us where we want to go with malaria elimination. I think we need visionary leadership, and leadership that understands that it takes time. I put here a simple scheme of, how you might go, how you approach a problem. It's simplified, it's simplistic. So, don't take it like this is the Bible truth. This is just a simple way to communicate. You have to understand what you're dealing with. You've got to define the problem. You need to know how much it is, where it is, who is it affecting, some of the things that we've discussed today. You've got to then understand some biology, whether it's on the mosquito, whether it's in the human, the different stages in the human, to be able to say, okay, here's what I think I can do about it. You need to have a bit of knowledge on the biology, the immunology, the molecular mechanisms, etc. With that knowledge, you can design interventions. You can say, okay, I understand that this protein does X. If I make an antibody against that protein, that might help. So you can design your potential interventions. And once you've got an intervention, then you can test it. You can bring it back to clinical trials, see, well, I thought this was going to be a great vaccine. Did it really work? And if it works, then you've still got another stage of how you're going to implement it. And, can you store it at the right temperature, for example? Can it get out into the very rural areas, etc.? And at each stage of this simplified pathway, there's a learning, a trial and error process where you learn, you fail, you go back, you iterate. I couldn't draw enough arrows at the bottom there, but literally at every step you're learning, you're going back, you're refining your question, you're going back, you're coming back, and it's a cycle. And so when I talk about a skilled workforce and training our youth, we really need experts in each of these areas. It's not enough to have people counting how much malaria is and just that. You need people doing biology, you need people looking at interventions, you need people doing trials, you need people all the way through to government and policy and implementation. And without that leadership coming from us in Africa, I think that malaria is still going to be with us for a long time. And just to wind up, I think you also need scientific institutions that are strong. And this is one of the most inspiring ones for me. This is in Senegal. This is IRISEF. This is an institution built by an African scientist, just inspirational for me. And without institutions, where's that skilled workforce going to train? So it's so important that we have good institutions that have good governance, that have good infrastructure, good support, good training programs that allow young minds to innovate, to explore, and to advance. I think we need to harness diversity. We need to support female scientists more. We need to accept female scientists in our discourse in Africa. We need to harness the diaspora. There's almost a feeling of exclusion of diaspora because you left. And I think that that's not helpful. I think that all of us can work together to strengthen science in Africa, and that we should harness capacity wherever we can find it. I said funding, and I won't overemphasize that because of time. So in terms of concrete actions, I think to finish, this is the last slide. First, we must own the problem and all of its dimensions, and accept that it's complex. If it wasn't complex, we wouldn't be on this webinar. That to solve it is probably going to take a longer time than we would like, and that we have many things to fix in our ecosystem. So I think that's where we have to start, by owning this problem. This is our problem. It's nobody else's problem. Then we need to look at these challenges. They're tough challenges, but how can we turn them into opportunities? How can we create environments where innovations can come up? Innovations in turn would create jobs. Jobs would lead to better health. Health will lead to wealth. I think we can turn a negative vicious cycle into a positive cycle that in fact generates wellness and generates health, by looking at those challenges and turning them into opportunities. And I feel that the key is the youth, and giving youth an environment where they can actually grow and come up with these solutions, giving them infrastructure, giving them leadership. And so at the end of this webinar, for me, it's what we are, the change that we seek. And what I say to myself is, well, I can't fix everything. You know, if you think about the totality of it, you want to go home and lie down and say, well, it's too complicated. But we can't do that. We have to be the agents of change. And what I ask myself is, what can I as Faith do? And I'd just like to challenge those of us here in the meeting today. What can you do in the sphere of influence that you have? There is something you can do. And I look forward to our discussion. So I'll stop there. Thank you.
Yeah, thank you so much, Professor. Yeah, it's been very packed. I know you cannot use 20 minutes to really give us everything, but I like the way you've really put all the slides together. Very simple and easy to understand. It's a great talk actually. And I know it's something that we really need as Africa, and also as journalists, because there are a few things that I'm listening here and I'm like, yeah, And I think in you talking about how we need to harness the science, even with the diaspora and all that, and knowing that malaria is one of those that are affecting the most vulnerable in the society. I've seen some questions. Continue. Am I audible? All right, so yeah, I'm saying there's some few questions I've seen on the chat box, but I'm thinking we continue first of all so that I will be giving you an opportunity also to answer those questions. And I'm asking everyone else who has a question concerning what the professor has talked about, just write your questions and then I will be able to give her a chance later so that she'll be able to give us an overview and answers to all our questions. But yeah, thank you so much. I've learned something new, silent infections. I didn't know that we have this. So that means we have malaria all over. But I think right now, thank you so much. I want to go to the questions to our panelists also, because I'm thinking probably they'll also have some few comments on your presentation and maybe they will be able to ask also questions. So right now, allow me to introduce some of our panelists, and one of them I will start by giving them a chance to give us the answers to a few questions that I have here. And I'm going to start with Dr. Doni Mategula. You will forgive me, people, if I will not have gotten your pronunciation to your names. This is Africa, but we have very difficult names sometimes to put it across. So Dr. Doni is a medical doctor. He's also an epidemiologist. And right now I want to give him a chance. He's also the deputy group head of the infectious disease at Malawi Liverpool Wellcome Clinical Trust. Dr. Doni, you are responsible in designing and implementing epidemiological and malaria in Malawi. So the question that I would want you to delve in and you give us what you have been up to is that why are these studies and what are these studies that you're involved into? Why are they important to us in Africa? And as we head towards eradicating malaria. So as you are at it, let's just listen to your presentation and you give us much about the research that you are involved. Welcome.
Thank you very much. I didn't expect that I would present something, but rather talk through what I actually do. You pronounced it rightly, so that was
Thank
good.
You.
Yeah, it's all Bantu language, and I noticed that I might be the only or very few Malawians on attending the webinar. So I'm not only representing the Malawi Liverpool Wellcome Trust, but rather Malawi in general. As you had already said, I'm a medical epidemiologist. Back of our, I'm saying our because research is always a team effort. Is in Malawi actually at the Malawi Liverpool Wellcome Trust with a lot of collaborators outside Malawi. With Faith, we probably have crossed paths that you don't know, conferences and many other places, but it's a very, very small world in terms of malaria. The one thing that I wanted to at least say is that Faith has actually mentioned the changing epidemiology of malaria for Africa in general. But I would like to pick specific points to that of Malawi, where we see that we actually acknowledge and triangulate that fact that indeed transmission of malaria is changing. And what is increasingly becoming difficult for all malaria experts is the fact that it's the fact that there is heterogeneous transmission. You have one country, but in one part of the same country, you do have a lot of malaria, and then other parts of the same country you don't have. speaking for Malawi as an example to that fact, by the end of 2022, we were ending our 2016-2022 malaria strategic plan. And we sat down as a country in technical working groups and various other platforms to think through what is going to be our next move now that we have progressed to this far. We sat down as a country, and I speak because I've been part of all these platforms, and did put up ambitious goals of eliminating malaria in Malawi by the year 2030. And that is in line with a global technical strategy. We acknowledged the challenges that putting up elimination goals for a country like this one, what it would bring. And we realized that we cannot work in isolation as a country. I am actually speaking about this because malaria itself does not necessarily look at the borders that we do have in Africa, but rather it works as a parasite or as a mosquito independently without looking at that. As such, both the research activities and all the new tools that we do have in the package need to acknowledge that fact. One thing, before I actually go into the specifics of what we do, and I would like to reflect from Faith's presentation, is that, yes, we do have an intervention package for malaria, but the problem that we currently have is that it's not exactly expanding. The same vector control activities that we had 10, 20 years ago are probably still the same, with just a few that have been added. The same treatment options that we do have. There are very few changes that have just happened over the years. And we seem to be facing new threats, for example, things like anti-malarial resistance and other emerging threats such as climate change, which means the last bit of eliminating malaria is going to be quite challenging. At the same time, we need to ensure that we are wise with our current intervention toolpack so that we are able to deliver it effectively. Speaking for Malawi, one of the other things that we actually did as Malawi Liverpool Trust, our specific work, as you asked me, was we supported the National Malaria Control Program in what we call malaria burden stratification. We know that it's important always to quantify the burden of malaria in a country so that you should know where to do what. We did this exercise, and I'm happy to share the resources around this to ensure that we know that in the next strategy from 2022 and to 2030, we know what we're going to do what and where and by how much. This is one of the key things that other African countries can actually learn from. And I do realize that Kenya has extensively done burden stratification, Tanzania, and many other countries which the WHO has classified as high burden, high impact. That has been one of our key works at the Malawi Liverpool Trust, supporting the ministry to effectively know which interventions to deliver where and what through malaria burden certification. We have also been involved in the evaluation of the RTSS malaria vaccine. You probably know that the RTSS malaria vaccine has been evaluated in 3 countries, Malawi, Kenya, and Ghana. We have been, the team that have been doing that safety evaluation for that vaccine to ensure that it's a safe vaccine. We understand the challenges that it might have in terms of a modest efficacy that would actually wane, but it's actually the best that we do have. Some of our other work at Malawi Liverpool Trust involves mitigating anti-malarial resistance. It is actually a new threat. We know that at the moment we treat malaria using using artemisinin-based combination therapies, such as lumefantrine artemether for many other countries, or Coartem. It has so many different names depending on where you are. And we saw in Southeast Asia that there was extensive resistance to this drug, such that it was very difficult for them to actually curb that resistance. And it's a challenging thing to have in a country. Within Africa, we've only noticed a few reports from Uganda, Rwanda, and some parts of the Horn of Africa that there might be emerging resistance. So one of our key works at our institute is to see how best we can mitigate anti-malaria resistance within Malawi and also within the wider wider aspect of Africa, collaborating with national malaria control programs to see how best we can actually prepare for this storm, as I like to call it, because it is also another emerging threat that we do have within the malaria space. My final remarks, I think, to speak around the issue of research and development, I think, irrespective of our tools or specific work, I think what we need to be doing is actually to promote research and development, especially in the development of new tools against malaria. That should be one of our key priorities. And realizing that that aspect might actually take long, the other thing we need to invest in is effective delivery, and even the research that actually goes into the effective delivery of our own existing tools, alongside strengthened health systems, surveillance systems, so that we're able to at least do better with the things that we do have effectively to be able to eliminate malaria within the African region. Thank you very much. I've touched so many areas. I hope I'll get specific questions from the members. Thank you.
Yeah, thank you so much, Doctor. I think something that is really coming out from your presentation and also from professors is that we need to really promote our research and development. And thank you for your time. I am again asking people to send their questions. We'll be able to get time to read their questions and have them answered. So right now, let me go to the next panelist, because we also have to give them 10 minutes each, and then we will wrap up with the questions. And right now, I want to go to Dr. Benoit. It's a very handful or mouthful name there, Dr. Sesno Benoit Asogba. I hope I'm also getting your name right. And Dr. Benoit is a postdoctoral research scientist, the Medical Research Council Unit at Gambia, the London School of Hygiene and Tropical Medicine. And right now, I want just to ask Dr. Benoit if you can be able to give us your presentation. How can governments, bodies, universities, research institutions in Africa support young researchers in building their capacities for research and getting a large talent pool of researchers working to find the solutions to address malaria issues in the continent? Based on what the professor talked about earlier, she talked about how we really need to support our research. And today we are talking about research in ending malaria. So from where you are, talk to us about this research and how we're supposed to actually empower these institutions and research institutes. Dr. Benoit.
Thank you, Emily, for the nice presentations. I'm sure you get my name right.
Thank you.
Yeah, it's a French name, but you got it right. And then I would like to thank the rest of the panel member and Professor Fates, which I have the opportunity to chair this, to be in the same panel with her. Listen to many of her conference, and then also TED conference. He did very impressive talk for me all the time. And then she's one of the scientists in Africa continent that inspired me. When she's talking about how they move from the tradition to the technology and get involved to sort of the health challenge we have in the continent. I have been like the question was kind of building the local capacity, and that's the last of the end of the slide of Faith, talking about how can we transfer the technology, the knowledge to the generation, and how the government interfere in that. And that is something I have contributed that as a researcher, and I have been the product of that because some people contribute on me because before I can be here from the government, where I will start with my story where I got the government scholarship to build up, to get them up to master level in biochemistry, molecular biology and biochemistry before moving to the Minister of Health, where I got opportunity for partners like OPMI from USAID to do masters in molecular entomology to support our national malaria control program. I think it's 17 years ago now. And then I said I have been a product of that. And then from that, I belong to get a PhD. And then all the time I feel like I have to give the hand back to the people behind me so that they get proper trainings and then also have the opportunity to contribute to the health challenge we have. And from that, when I finished my PhD, I got different postdoc positions. And then I have trained different master research interns and then also organized the basic training to support the National Malaria Control Program and then to support different institutes from the sub-region in West Africa where they lack the capacity of molecular, lack the capacity of basic entomological surveillance for malaria control and elimination. And then on that, I also going to talk about what concerns the country I'm living in, Gambia, where we are aiming for malaria elimination in 2025. But although the prevalence is really low, but we are facing the challenge of cross-border malaria transmission, where in Senegal at some point, we have really relative higher prevalence, and then we bring the interest of cross-border malaria control, and then we bring the interest to regionalize the capacity building, not within one place, but within the sub-region to be able to eliminate malaria, not in the country. And then last week, I have received the director, Dr. Daniel, the global malaria program, the director of global malaria program, and his interest on how that we can develop regional, how we can develop malaria, Gambia malaria elimination plan so that at least in some point in the continent, we can eliminate malaria from some location within the continent. That should be one of his targets at the time he's taking over the GMP program. And then coming to the government, how the government can support. There's different, I don't have present, but at least different steps where governments and then different aspects that we can be built to support the capacity building using the technologies and then across the different level of malaria transmission. As Faith mentioned, that the complexity is high, and then we have to build on different aspects of that complexity to be able to face the challenge. And then one of those things is the funding and the grants where government will allocate sufficient funding to support malaria research and establish a grant program to support youth researcher in the continent. That's something that is many countries lack. I know Kenya, they have kind of some funding from government, but that one in South Africa as well, but that one is lack in many countries in the continent to support researcher, youth upcoming researcher. And then from that, you have also the research infrastructure. Research infrastructure, to have a proper research infrastructure in many places is to support the research development, to support the program, even to enable the monitoring and surveillance of the diseases is one of the challenges. And then, I'm happy that during the COVID pandemic, and then a lot of the bring opportunity to leverage some molecular equipment sequencing. Currently, I'm at the head of genomic sequencing and the molecular diagnostic department at the unit. And then we have trained a lot of people from the continent how to sequence the COVID, how to sequence other genome sample across the continent. And then because of COVID pandemic, it's given opportunity for the government to invest a bit, because they feel the fear of how to increase the surveillance so that their health will be, and they feel the fear that how to increase the surveillance so that they feel a bit protected from the infection. And then from that one, you have to, in the continent, there's something that is also lack, is a mentorship program to assist the upcoming scientists, upcoming undergraduate students, and then get them interest get them interest on the research, and then share them the different opportunities, and then so that they'll be able to make their choice, and then assist them on their career. That's something is not everyone have the chance of that one, but people have that chance. They build on and become a really good scientist in the continent. But that's something that's lacked at some point, and then we have to build on. But I all the time take opportunity when I have chance to assist students or colleagues, and to develop in their career. To do that, I don't. I all the time support them do that one, so that they can be in next 5 years. You meet a colleague, you meet at successful scientists, and then so that we can more collaborate. And then another thing I have thought about is a collaborative network on malaria research. That is something encourage the collaboration, knowledge sharing amongst universities. And then many of us, we feel like holding the ownership of everything. But I thought it's good to hold the ownership of common goals, and that limits our collaboration between different institutes, between different countries, so that, and then share our data so that we have a set of common goal, common objective. But I can feel that within the continents, the collaboration is something that lacks. But there's more collaboration between the West, the African continent, and the northern partners from UK, France, or America, and then rather than more south-south collaboration. Yeah. And then also recently, the Science for Africa was setting the shared data platform. We're trying to set up the shared data platform so that in the African continent, when you need to turn the clinical trial, how you can get access to some data. Then I thought those things, we don't have a strong regulation for data sharing, and the government and research institutes should facilitate access to relevant malaria data and samples, where we can, the youths can have access for necessary resources to carry out their own studies, all those things. And the other thing is policy, public awareness, and advocacy that we have is something the government, university research can also play a vital role, because at some point it become the political the government have to take action, and then make the thing thinking to make the thing happen. And then that is something we really need more government implication, political implication, so that what coming from research, like vaccine, and so all the safety, all the trial, and then set up a proper regulation so that there will be and policy so that population can get access to those different tools from the technology, from the science, from lab, is something that is will play a vital role in raising public awareness for malaria. And then I will stop there now and leave the handover to the rest of the member of the panel. Thank you, Emily.
Thank you so much, Dr. And rightly you've put it, it's about policy, the government funding, and also supporting our institutions. And that's why right now I want us to go to Dr. Susan Mbahale, who is a senior lecturer at the Technical University here in Kenya, to talk about, of course, now the previous speakers have talked about how are we going to empower our institutions, what are we doing in terms of research, and how are we going to involve our institutions. So Dr. Susan, being one of part of the institutions of higher learning in this country, I would just want to hear from you maybe the capacity needs of higher learning institutions to produce quality malaria research and to inform politics and program implementation. Maybe you can take us through that, Dr. Susan.
Thank you very much. Thank you for the invite, and I'm glad to be part of this discussion. So I have very few slides I would like to share. So it's about capacity needs of higher learning institutions to produce quality malaria research for policy and program implementation. Okay. So basically, higher learning institutions are considered, or they are basically centers of excellence in terms of generating knowledge and rigorous research and teaching. And basically, if you look at Africa as a continent, we have many of them, and they are at different levels. I would say some are very advanced depending on when they're established, and others are still very young. So there's that variation. And then we also have variation in the sense that some of them are basically just focused on research, others on teaching only, and others, they give both research and teaching equal measure. So you'll have such differences among the various centers of excellence. So when you talk about quality research capacity, what does it involve? It involves the skills being developed, the quality of research environment, funding, adequate infrastructure, the research incentives involved or that are used to motivate the researchers, and time available to the researchers. So I've borrowed a lot from Professor Sawyer's work, who really looked into this and actually has produced a whole chapter on the issue of quality research in Africa. So a bit of what I'll discuss I've borrowed from his work, which is still relevant to us even now. So research capacity needs, there are more, they are much, much more beyond the individual brilliance. For you to consider yourself a successful institution or higher learning institute, basically it's more than the individual brilliance and the hard work or the work of a team. It involves other factors like the nature of and quality of research environment. And you see that you find that in the environment, it also includes the facilities and what other work has been done by other researchers that are related to your work. And this is where the other panelists have already brought in the idea of multidisciplinarity. So let's look a little bit more on the research environment. It is broad. It includes the societal conditions, the society itself. How does it view research? Do they take into consideration the results or what the researchers have found out? And also institutional condition. As an institution of higher learning, the organizational structure, the management, and the materials available to support research are also critical. So you find that traditionally, the research model was more of individual or small groups of people coming together or interested in a particular topic of their choice or area of profession. And this was mainly discipline-oriented or university-based. You find traditionally maybe a university would have money for only this work, and basically so their interest would dictate what would be done. Sorry for the background noise. So however, in recent years, things have a bit changed. There is reduction in institutional funding for research. And you find that mainly we procure these projects. We are procuring directly from the donor, so they would advertise for availability of funds in these research funds for this particular work, and then we researchers apply. And therefore you find that in this scenario, the university may not really be involved. So it's you, the researcher, and the donor. So with the minimal support, this ideally, because this is what is happening mainly, you find that there is minimal support in building institutional capacity. And oftenly, we don't have a say in determining the topics. Ideally, they're often determined externally, and you find most of the times they may be of little relevance to the local situation. However, whereas it may look a bit disadvantageous, it's an advantage to those seeking to pursue maybe PhD level of studies, postgraduate studies, and postdoctoral students, because then you just apply, you get the scholarship or the position, and you move on with your studies. This is good in the sense that then we have a pool of graduate and postdoctoral students. So again, on the environment dimension, you want an educational system that encourages and equips people to be curious about basically the nature and society and develop interest in pursuit of knowledge. So the environment is very, very important in determining just how much a researcher can do and how far they would go. We also have the social policies and practices that encourage and facilitate the flow of information and of course, reward of innovation and inquiry. There is, I would say, I've observed a missing link between the science that we do and translating the science to the policymakers. So we have a lot of theses are lying in the libraries. We have a lot of publications, but the problem I see is a lot of information has not been translated to policy, and it has not even reached the legislators and of course the parliament. So this is a big gap. The ready utilization of good ideas provide a powerful incentive. You realize if you study something, you come up with an innovation and it's easily taken up, or the idea is taken up. This provides a good incentive to, and it motivates the researchers to actually continue. And especially when we have a case where there is evidence to transform lives. So researchers, basically, they need to be involved in policy making. I've just already mentioned, there seems to be a missing link, a lot of published papers. However, they don't seem to be informing the policy. Then the issue of underfunding, I'll not emphasize on this. The other panelists have already raised it, but you find that the strained economic circumstances, again, we are talking of Africa as a whole, we are not at the same level. One country may be doing very well, another one may not. So we see that there are strained economic circumstances. And in the recent years, we've seen a policy bias against financing of higher education. And this, what it means basically, then there is not much funds available for research. And of course, the funds that are available are channeled to to budget lines that are of more urgency. Then the idea of most of the public institutions, we look outward. We look outward for funding. What I mean is, most of the time we are applying for grants from outside, not within the continent, not within the country. We don't have maybe budget lines for that, as I've already mentioned, strained economic circumstances. So what happens in this case, market forces the resources away from support for local production of modern knowledge. So what I mean is, when you look outside, you are basically, you will satisfy the need of that other person who is outside. Again, the money, you don't just get it like that. There are conditions for it. If it is a scholarship, you have to satisfy the needs of the sponsor or the donor. So for as long as we continue relying on the outside, then again, you realize that we lose our power in terms of continuous support of local production of modern knowledge. Then on institutional conditions, again, you can have very brilliant researchers, but if the institution is not supportive, if there is not enough research infrastructure, again, it's difficult. For example, in terms of the laboratories, the equipment, the management system, if it is not supportive, you find that people give up. And policies that facilitate and support research enterprise, including incentives. And again, incentives doesn't need to be money per se. It can just be having a good system in place that, for example, responds promptly. If it is budget issues, you're having a problem, there is somebody to assist you in such a thing. And then they are able to respond, of course, to in terms of reporting, they are able to support. On the other hand, the job market by large does not adequately reward advanced study. Again, this is debatable. It just depends where you are, but you've already raised the issue of incorporating the youth and mentoring them. So one thing I see that people say, no, we cannot take up this course. We don't know the job openings if they're there. So the market, and if you were to just survey around, you find that yes, people have, a few have advanced in their studies, but the main complaint is they're not being rewarded adequately. In the recent years, research on research management, the recent years, you see now there is a move towards multidisciplinarity. There is a move now from being away from individual researchers. Now, many donors are basically dealing with the organization. So they are favoring large-scale research, more applied projects, and away from individual research projects. So there are basically many funders are seeking institutional assurance of institutional oversight for funded projects. So the institution needs to have a clear and transparent way of procurement, management, monitoring, and certification of projects. And institution management of and support, it should actually have the support facilities and skills and systems that are critical for this, for research management. So what I've observed poor institutional responsiveness to donors have become a major drag on research performance. And what this has done in turn is basically has led to frustrations of talent and brain drain. So if your institution cannot respond adequately to the donor's requirement, again, this has been a hindrance. On time availability, depending on where one is, we know that research requires time. So if you are a lecturer and a researcher in an institution where both teaching and research are given equal priority, therefore you find that time for research is quite limited. So ideally, but since we've gone through Corona, you find that there's a bit of flexibility in the schedule, or rather now, at least the management is open to flexible schedules. So with flexible schedule, then this could be a solution in terms of time availability for researchers. I'll end here, and now we'll wait for your questions to respond. Thank you.
Thank you, Dr. Susan, for this presentation. Actually, you've raised something that is a bit, it's been out here, people just talking about how they do not know the field of science, how they are taking them. Even for us to advise our children to take science as a major, it's tough because they think and they feel like it's not really supported well. So thank you so much. And I think we will have questions for you and the rest of the panelists after this. But right now I want to go to Dr. Charles Mbogo, the professor actually, sorry, Professor Charles Mbogo. Professor Charles Mbogo is a public health entomologist with over 30 years experience in the field of medical entomology and parasitology. And right now he's been working for so many years, actually. He's been working on the research science and he is the president of the Pan-African Mosquito Control Association. Professor, based on your background and actually what you've been doing in terms of just looking at eradicating malaria in this country, maybe you could take us and share some of your major challenges in the field where scientists are facing, because actually we've heard from some panelists the challenges that scientists are facing out there, and now the contributions of African scientists in this course of ending malaria and science. And as you go and give us your views, maybe you can also give us how are we going to enhance the capacity in Africa, actually, just to enable African scientists to be key agents of change in ending malaria in the continent. Over to you, Professor.
Okay, thank you so much, Emily and the panelists. I hope you can all hear me.
Yes, we can hear you, Professor. Go ahead.
Sorry, I'm in the field right now, and possibly you'll get some interruption from the outside, but you bear with me on that. And as you have said correctly, I'm a public health entomologist who has got extensive experience in the use of vector control tools and how we can be able to eliminate malaria in Africa. And the question that we ask ourselves is this possible? Why has it taken us so long to do that? But to me, this is very, very possible, and we can be able to eliminate malaria in Africa because it has been done elsewhere. Why is it that Africa is a big problem where we can be able to control malaria or eliminate malaria in this particular instance? I'll start by when I actually was a young scientist, and there came an issue where we have to develop tools to control malaria. And Kenya, Ghana, and the Gambia were chosen to test the use of bed nets to see whether they reduce childhood mortality in Africa. And all through we did all that particular projects, we found that this is actually very possible, that if we distribute bed nets in the communities, we will be able to reduce childhood mortality as well as malaria cases in Africa. And therefore, this was taken out as a policy dialogue that went ahead, and WHO recommended that all African countries and across the tropics, they should be able to use bed nets for use of vector control. And once this one was actually taken out from the year 2000, we have seen a much greater decline in malaria cases and deaths all across Africa from the year 2000 to the year 2015. After that, we have seen malaria stalling and not really going down below what went up to 2015. And the question we ask ourselves, what is happening? And we came to realize that after putting all these efforts, a lot has actually happened. and we were faced with greater challenges, especially biological threats, including resistance to insecticides that were used in the bed nets and resistance to drugs. And policies has to change now and then. And so in that case, we had to move forward to see exactly what else is actually contributing to the stagnation or stalling of malaria decline using the bed nets and indoor residual spraying. Yeah, you know, the current conventional methods that are currently used are the long-lasting insecticide nets and indoor residual spraying, as well as now as a complementary tool, we are using larval source management. In this particular case, we find that it is actually possible to eliminate malaria. It has been done. Even in Africa, we have countries that has been able to eliminate malaria. And so why is it that we find that in China, which had about 30 million cases of malaria, when we were able to eliminate malaria to zero, yet in Africa, where we have a lot of malaria, we are not able to eliminate it, even within the span of 20 years. Yet China was able to do it in 5 years. What did they do? So we have really to see how we can be able to learn from other partners and see how we can be able to use that. We know the burden of malaria in Africa is almost over 90%. And in this particular case, what can we do on this issue is basically to include or to expand the vector control toolbox to include emerging technologies that we can be able to use other than continuing with the same tools. We have seen the challenges of insecticide resistance, drug resistance, and outdoor transmission because nets are there inside, but outdoor, when people are there, transmission is also taking place. There has also been a shift of the vector by biting early before you get to bed or biting late when you are out of the bed. So all these biological threats needs to be understood at the local level so that we can be able to know what kind of tools are we going to innovate and develop in order to overcome those biological threats. We have learned quite a lot from the COVID-19, whereby within a very short time, we are able to develop a vaccine and diagnostics. How did this happen? This happened because we were able to share information very, very quickly. And so the lessons that we have learned from COVID-19 will help us to rethink malaria and make our assumptions and approaches that we are going to use in order to come up with the best solutions for malaria control and elimination. The COVID-19 has laid bare the limitations and the inequities of our global health systems, in particular challenges related to governance, service delivery, and integration of the workforce. So what are we saying? We are saying that since the year 2000, when vector control came to be a mainstay in the control of malaria, it contributed to a greater extent more than drugs and vaccines. And it has been responsible for shrinking the malaria global map. And in this case, then we see a lot of funds now allocated to malaria eradication using various interventions in Africa through the Global Fund, President's Malaria Initiatives, and many other donors are coming in. And the question is, how can we harness these resources so that we can be able to put our efforts towards the elimination of malaria? That is the key that we need to think about. So what needs to change here is the way we think about malaria, the perception we have for malaria is a disease of the poverty, is a disease of the poor people. But look at that problem as a developmental problem, but not as a medical problem. What do I mean? If we develop the countries, and we have seen mostly in developing countries, that they are able to deal away with malaria because they have been able to develop their areas and they have been able to come up with very good ways of developing and implementing more diverse and effective sustainable malaria control strategies, especially the use of good housing, use of environmental management, and the use of all these has become very good because, for one, the people on the ground are able to use these tools. And the people also on the ground are able to achieve much. But what has happened in Africa, where we could possibly be able to kill off the vector populations using these tools, having a combination of mosquito-proofed housing and environmental management, then we don't have that. But if we do that, then we can be able to utilize it in Africa, because if we can do so, then everyone takes charge and is able to understand the environment in which they are living in. Now, the question that remains is, yes, we have made all these strides. We have improved a lot by scaling up these vector control interventions. And we have seen malaria transmission declining. For instance, in Kenya, it went down from 80% to currently about 20% in the lake endemic region. And in other areas now, if we look at the whole Kenya now, we have it coming to about 5 to 8%. But how can we be able to drive it below zero? We need to improve our research capacity in all aspects of malaria control and elimination, such that we use all the tools that we have, integrate them in a better approach that brings in all stakeholders, partners, and other collaborators together so that we can be able to solve this particular problem. So the whole issue is based on funding and how funding is going to be devolved. Basically, what we are looking at is we are relying heavily on external funding, but we are also seeing the domestic funding from our governments. But how do the governments really position themselves so that they can be able to work very critically together to harness using the domestic funding that is available and the external funding that is available, so that there is good coordination, good management of the tools that we have and the approaches that we have, so that we can be able to have one clear goal, a malaria-free Africa. Now, if we can be able to do that, then we need to rethink on the way we train our personnel. We need to rethink how the human research for resources for human health is harnessed, and how we can be able to increase the shortage of staff that we have with the relevant skill sets and relevant competencies that can be able to drive malaria in the right direction and reduce and be able to make the decisions in the right way. Now, when we look through all this, we need to identify the gaps in the training needs of our forces, of the workforce. And this, we need to see that we get access to data. Quality and quantity data is more important. at all levels. We are talking at the national level, we are talking at the sub-national level, and at the very local level. All these people must be able to work hand in hand and be able to collect that information. This data needs to be properly analyzed in order to help you with the decision to make the proper decision. That is what we refer to as evidence-based. And in that situation, then we see that we need to increase our capacity, either technical capacity and non-technical capacity, so that they can complement each other as we go along. I'll take an example of the community health volunteers that we have across the country and the use of public health capacity. What we normally see is that the community health volunteers do a great job, but they are never recognized, even if they go to ask for another job elsewhere because they don't have the certificates. Yet they are trained to respond to particular issues in a multidisciplinary, multi-disease environments. They are there looking for HIV people and helping them to overcome the stigma that they have, malaria, and other diseases, other infectious diseases that are found within our communities. If we train these people, and we have many, many young people all across Kenya and across Africa, how can we harness these people? People who are trained at the master's level, at PhD level, at undergraduate level, they need to be taken up and be reoriented into the way we control and eliminate diseases. So this said, we need now to think about the available infrastructure. Do we have the available infrastructure? Do we have the available financial resources and equipment to do this? The more we have this, the better we are going to do this. I'll talk now from the point of view that I'm the president of the Pan-African Mosquito Control Association. One of the key and our vision is to have an Africa free of vector-borne diseases. And the vision can only be achieved if we train enough capacity. So one of the things that we have done is to select 3 centers of excellence across Africa, where we train people in different aspects from genomics to basic sciences, so that they can be able to use those tools for the control of mosquitoes and other vector-borne diseases. The issue here is, if we look, and when we looked at the African countries, actually we did a survey in 2016, and we found that across Africa, we have capacity, but this capacity is distributed in different areas. You find an entomologist is there as a minister or is somewhere as an administrator, but is not really doing the right work that is actually required. Secondly, we found that a lot of capacity is among the men. About only 28% of the vector control people across Africa, as we found, 28% is actually women. Now, women are critical in malaria control and elimination. They have our children, they have their family at heart, and this is where the problem starts. When a malaria strikes, it's actually the mother who first understands how that child feels. So we need to train more and more of this and remove the imbalance that we have. The next thing that we also need to think about is how are we harnessing these trainings? So we are thinking about the training, repurposing the tools that are going to be used. And what we now have is what we call the district entomologist that learns about the basic understanding of how malaria is transmitted within the environment in which people are living. Professor Osea saying that malaria is very complex. Yes, and it is very complex on the vector side. Because the vector, once you have put all these tools together, the vector changes its behavior and it no longer comes into the house, and then it will not be affected by the tools that you have. So what other tools are you thinking to add into the panel of what we have currently and what we can be able to add? The other thing is rubber source management possible in Africa? Yes, it is very possible. It has happened in the Europe, it has happened in the Americas, and right now they don't have malaria in those countries. There is mosquitoes, yes, but they bring in other vector control tools, especially larviciding, which reduces the vector population out. Why can't we go that way and do what can be done? And this is actually one of the visions that we have in Pan-African Mosquito Control Association, because we realize that the mosquito is the main culprit of malaria. If we remove the mosquito, definitely there will be no malaria at all. But if you remove the parasites, then you live with the mosquito, but it can be able to transmit other apoviruses and other diseases like hepatic filariasis. And so what we need is to rethink about the training and enhance the capacity of African scientists to be able to access and impact on the malaria control by retraining the people that we have so that they can be able to be responsive to the local ecology of the vector, to the local disease ecology, and how the disease is affecting the human populations in there, and see how we can be able to address and eliminate malaria in all areas. So to stop or to finalize this, I could possibly be able to say that we need to strengthen capacity in partnerships, in collaborations, and in coordination with all health sectors and other external sectors, so that we can all focus on the same thing. And countries in Africa must spearhead this so that they can own the process. We cannot wait for somebody from out there to come and tell us this is what we are going to do. We understand the problem better. And I always say that African problems will get African solutions. And that's all way we can be able to do. Thank you so much.
Thank you, Professor. And I think you've really covered quite a lot. And right now I have questions, a few questions on the chat box, and I see others on Q&A. What I'm going to do is that I will float all the questions to all the participants, and I'm kindly asking that you note your question so that I can give each 10 minutes to answer those questions, because time is really not on our side. We have gone beyond what we had planned for. So I think for Professor Osier, Faith, your questions, there are a few on chat Q&A. Somebody who sent has a very difficult name here. And so the question is, why are we Africans, Africans cannot establish malaria research team? Another question is, what is the main support of World Health Organization on the capacity building of malaria experts? There was a third one for Professor Faith, but I think our panelists, you can also chip in and give your answers, but kindly let's observe maybe 10 minutes kindly. And then we also have, what are the main reasons malaria resurgence in your country, if it is happening? So I imagine this is talking about the country where you come from. And then there was one question for Professor Faith in the chat box. Let me just go so that you can go ahead and answer all of them, Professor. And I think somebody had asked a question here. Yeah, sorry, maybe you can be answering those as I look for other questions. But there is also another question for Dr. From Zambia. How effective is malaria vaccine as of now? And what are some of the challenges that has come to pass after coming in with the vaccine? That is from Simon Mwale from Zambia. And there was also, I think, something else from For someone from Malawi, the doctor from Malawi, you have a question. Do you think malaria is eliminated in Malawi by 2030? As you know, we have symptoms cases in community, and testing by RDT may miss cases. Do you think sensitivity and gene deletion? That is for Dr. From Malawi. And then also you have, yes, I have seen the one for Professor Faith again. There's a categorization of malaria from severe, mild to silent. Is a universal observation across the malaria-prone areas. Then what is the reason for it, and how can it be used to optimize malaria management? So Professor Faith, maybe you can take it on.
Yeah, I'll be very fast because of time. So the first question was why we don't have malaria research teams in Africa. I think we do. In fact, we have a lot, but we can have more. And the challenges are great. And like I showed you, the challenges are multidisciplinary. So while you might find some people working in epidemiology or some people working in immunology, we need others working in implementation science. We need other ones working in vaccines. We need other ones working in vector biology. Within vector, there are many sections. And so although we have some teams, and they're good teams, actually we need more, because the challenge that is facing us is strong. Why don't we have more? Again, it comes down to what all the panel members talked about in their presentations. It's all down to funding. It's down to institutions. It's down to priorities. You know, for example, when COVID broke out, all the malaria work slipped because everybody who had a lab had to focus on COVID because it was such a pressing emergency, and other things like that come up. So I think we are not starting from scratch. There's a lot already that's going on, but we need it to be more, and that we need it to be sustained. In terms of the World Health Organization, in my view, they are a reference. You know, they can give advice, they can give recommendations, they can support training, but they also have to look for funding for all their activities. At the end of the day, I really would like one outcome of this meeting is that, you know, building capacity is our responsibility. We cannot say the government, the World Health, we must really ask me, what am I going to do? What can I do? And I think that the external institutions can help us. External institutions are very good for advocacy. They're very good for fundraising. But at the end of the day, it is our responsibility, and we have the capability. And so I think that's really what I'd like to leave here. The reasons for resurgence, Charles actually outlined some of them very well. There's, you know, there's been changes in climate. There's been changes in the vector behavior. The vector is adapting to the parasite. We also had some discussion about transmission intensity is changing. You know, when I went to Kilifi, there was so much malaria in the areas we were working. Over the 20 years I was there, it's really, really come down, but there's still a lot of malaria in other parts. So there's moving things, there's something moving in the environment. And the last question, I'm not trying to avoid the answer. I think there are multiple reasons why malaria comes back. And parasite resistance, insect adaptation, changes in climate, all these things contribute and play a role. And then in terms of severe, mild, and silent, I actually used those terms for the purpose of communication to a general audience. There are proper classifications that are that have been developed by researchers around the world, mostly in Africa, but have been developed into guidelines by WHO. So you can find actually more precise terminology. What I used there was for the ease of communication for this webinar. So yeah, thanks for the questions. Thank you.
Yeah, so I think, thank you. Quite well. And I want us to go straight to Dr. The other questions, I think, was for Dr. Benoit, if I'm not wrong. Go ahead and answer your questions. We just go because of time, and then we go straight to the Malawi.
Hi, Emily. Hello.
Yes, hello.
Yeah. I don't get what is the question concerns.
Okay, let me just go look at Yes, Professor, there was a question. I think, do you think malaria is eliminated in Malawi in 2030? And then the person who was asking the question went ahead and asked, as you know, we have symptomatic cases in the community, and testing by RDT may miss cases. So do you think sensitivity and gene deletion? That was, I think, the question that I wanted you to look at it.
Yeah, but that one is to be addressed by Professor.
I could take that one since it's asking about Malawi.
Oh yeah, sorry, I confused the two of you.
Yeah.
Go ahead.
Yeah, so I could take all the Malawi questions. Thank you very much. So there were several Malawi questions. The first one was around the malaria vaccine. In terms of its effectiveness, I presume you're talking about the RTSS malaria vaccine because we've got several that are in the developmental pipeline, but the most advanced of them has been the RTSS malaria vaccine that has been recently recommended by WHO for use in children in areas of moderate to high transmission. We know that from the phase 3 studies that were done evaluating the studies, the vaccine protected 4 out of 10 children that were given the vaccine. That is to put it in its simplistic case, but that was in a clinical trial setting. We have been evaluating its real world effectiveness through the pilot that we're doing in the 3 countries, Malawi, Ghana, and Kenya, and we're yet to understand its impact in the real world setting. So that was around the first question. The second was whether we can actually eliminate malaria in Malawi by 2030. I believe so. Just as it has been boldly stipulated in the global technical strategy for malaria. I think countries need to start taking that bold step, and I stand by Malawi for making that bold decision to say let's eliminate by malaria by 2030, and I leave, I think, to see that dream being achieved. There was a question on on gene deletion and whether the RDTs that we're using are actually working. I agree with you, it's a concern. I think you must be referring to an enzyme deletion, what we call HRP2 deletion. If we see that, if that deletion actually happens, you'd see that most of the RDTs that we widely use within Africa or within Malawi do not work. So what we know that might be a problem. WHO actually encourages countries to run regular surveys to check if there is widespread HRP2 deletion, so that decisions should be made whether continued use of the standard RDTs should actually continue or not, but it is a potential problem. I was also asked to share, this was actually in the chat, in terms of Malawi's epidemiology in terms of prevalence incidence. I just have one slide, I think, to share. Oh, okay, I cannot share. Oh, okay, thank you. Okay, so a bit more about Malawi. A bit more about Malawi is that in terms of the indicators of burden and the indicators of disease burden include malaria incidence, malaria prevalence, and malaria mortality. We have been on a downward trajectory. The graph I'm showing you shows both incidence per 1,000 population indicated by the blue line and the red line indicating mortality or deaths due to malaria per 100,000 population. We see in terms of incidence, it's been up and down, but in general on a downward trajectory. And so is mortality. We also measure malaria burden through prevalence. This is through surveys that we do about 2 to 3 years. And again, I think for Malawi, there's been a downward trajectory with our most recent survey reporting a prevalence of 10.5%. I mean, there are lots and lots of efforts to try and characterize malaria burden below the country. You know, these are mapped estimates which we have published looking at malaria at 1 kilometer square grids. This is malaria district level again at there's been a downward and more heterogeneous picture that we noticed. And more recently, we did what we call malaria burden certification. I think I tried to allude to in my talk, and this is the picture that we're currently seeing with more transmission in the central areas and a bit more sparse in the north and southern areas. So you asked me what is actually contributing to the decline. Just as it is with many, just as it is with many other countries, it's difficult to attribute one intervention to the success that you're seeing because it's a mixture of many other interventions. In Malawi, what we've noticed is that over the last 2 decades, there's been a scale up of the available malaria control tools. And what I'm trying to show you is this timeline. We started off with bed nets somewhere around 2007. Then we scaled up on them. And when WHO stopped recommending monotherapy or other treatment of malaria using a single drug, we introduced artemisinin-based combination therapies. And then we also added in indoor residual spraying. We expanded the test using the rapid test. We started distributing TBO nets. So these are a special group of nets that are better than the traditional ones. We introduced artesunate for severe malaria. And more recently, we noticed we introduced a malaria vaccine in our intervention toolpack. So you see that over the last 2 decades, there's been a scale up of all these interventions. And I think you cannot attribute your decline to just one intervention, but it's a mixture of all these mixture and interaction of all these interventions that are actually leading to the decline that we are observing. And I presume it's the same case for the other countries in the region. So what I would say is that the goal of eliminating malaria involves better use of these available tools, and again, more innovation, and us owning the interventions that we're actually doing and ensuring that there is equitable access of all these interventions that are available, and not forgetting innovation. So I guess that answers your questions, and feel free to reach out in case I haven't answered some of them. Thank you.
Thank you, Dr. Doni. We are really running out of time. I've seen Professor Faith is leaving because I think she has another meeting, but we are winding up actually. So I would want to, there's one general question. I don't know who would answer this because somebody is asking, what does it take for one to be part of the malaria research team? Briefly, maybe Benoit, you can just answer that very shortly, and then we wrap up this.
Okay, thank you so much, Emily. Before reaching that answer that question, I would like to emphasize on what Faith have replied regarding the WHO on the capacity building of malaria experts. The WHO is mainly made to as a guidance, guiding developing the policy for the capacity buildings is us as the research scientists who how to invest some of our time to build a capacity, build a malaria research expert by assisting, mentoring, and then attracting funding, developing different research. And then regarding the resilience of malaria, we are having that one currently in the Gambia from 2020 to 2023, where we haven't seen the case of malaria increase. And then one of the hypotheses is linked, is associated to the COVID. Because during the COVID time, most of the intervention cannot be implemented. And then another thing also, which is really challenging to malaria transmissions, is asymptomatic cases, which constitute the reservoir of transmission. And that is a high part of malaria transmission that is not quantified, how this contribute to the, and then maintain the regional transmission ongoing in the community. And then those are the things that may be associated with the suggestions of the malaria in many places, not only in many places in Africa. And then to be part of the research team is, as Faith said, there's a lot of research teams in malaria research team across the continent, from South Africa to Nairobi, from East Africa to West Africa, in Burkina Faso, in Gambia, in Kenya, in South Africa, in Malawi. And then it depends of how to maybe, if we are really interested on doing a master's or doing PhD, how to be targeting some of those PI, some of the PI from place you're expecting to be. And then maybe on Twitter or LinkedIn, and then if the opportunity shares, you can be aware. And if you are going to do masters, or you can also write an email to particular team you're interested to join, because you're interested to develop a kind of work in advanced technology work or molecular or stuff. And those are the strategy you can put in place to join any research team, either from calls, it's open, either from personal discussions, so that we can share with you, okay, there's opportunity here to have someone, or you can come for internship, and then we see how it's going to be. And then those are the kind of strategies. And then as a researcher, I do that one to get another collaborator from other places to get involved in some proposal. We're going to submit or something and email them, say, okay, I know you can do ABC, you are capable to do this. Do you be able to get involved in this proposal where we cannot have competency here to carry this part of the project? And then you can be able to do that. And then those are the things we as a researcher, we're still doing it. And then if you're interested to join any particular team, either you look for the call from those particular teams from Malawi or anywhere, either you contact directly with PI, and then all of our emails is just put in the Googles. Either you get a personal email or either you get a professional email to reach out to relevant malaria scientists you're interested. I think that's the strategy you can use in place to reach any team across the country.
Thank you very much. Thank you very much, Dr. Benoit. And because of time, again, I would just want to thank every participant that have been with us today. And thank you to our panelists. I want to just go straight and give Professor Richard Mukabana, who is the Project Director Health Platform, to do a recap, and then we wind up our webinar this day. And again, I want to thank you from my side for listening all this time. We've had like almost 2 hours. Thank you so much. And Professor Mukabana, take it over.
Thank you, Betty. I hope you can hear me very well. Time is really gone, but I'd like to thank everyone for having found time to attend this webinar. It's the last webinar in a series of 5, and the first webinar was on Malaria Day this year, and the theme was time to deliver zero malaria, invest, innovate, and implement. Today, we've been privileged to have very good speakers, people who are exceptional in their own fields of work. And I would like to do a recap of what has gone on today. We had a lot of information coming from our keynote speaker, and that is Professor Faith Oser. She talked about many things, but I just picked out a few things I thought would be very useful for us to take home. And that is that think about the whole population when you're trying to control malaria. There are segments in the population which, if not targeted, will never get to zero malaria. So that was a very useful information. She also mentioned about the need for a multidisciplinarity. That is really useful. And as someone who also holds an MBA, Faith talked about something which we hardly talk about in our world of malaria control, turning challenges into opportunities. And I guess that's what many of the people have done around the world. That would have been a very important topic for a future webinar. Maybe we'll think about that. And then Donnie Mategula from Malawi, thank you for attending this meeting. There are 2 main things I heard from you. Maybe there are more that I didn't capture. You talked about malaria burden stratification as one of those things which other countries can borrow from Malawi in the fight against malaria. And I'm not sure I heard this from other speakers. You mentioned about mitigating anti-malarial drug resistance. You talked about how things went in the Far East and how Africa should start knowing what to do before things go south. We've seen some of these reports in the 2022 World Malaria Report. Benoit, you brought about the issue of cross-border malaria transmission. So we know that this exists, but African countries seem to be doing little in terms of cross-border malaria control. I thought that was a very key message. You also spoke about the need for government funding in R&D, mentioning examples from Kenya and South Africa where that's already working. If you have local money, then you tend to solve local problems. If you get external money, sometimes you don't meet certain conditions. And then Dr. Imbahale, you talked about quality research in Africa. And you spoke about a very important issue, the missing link between the hard science that we do and the policy side of things. So the issue of knowledge translation, the use of evidence, seems to be missing in our mainstream science that we do. And I think a bit more effort should be put in that side of the equation. Then Professor Mbogo, you gave me a new message today, although I'm in this area for a long time. You said we shouldn't just look at malaria as a medical problem. It's important for us to look at malaria also as a development problem. And I think people that do the hard sciences, we hardly look at things from that perspective. When we know the savings we can make from eradicating malaria, I think maybe we'll add our efforts there. You also talked about the need for access to data at all levels, whether grassroots, subnational, and national. That was really important. And then you gave the example of China, which I thought was very good for all of us to know. China, with 30 million malaria cases, were able to go to zero malaria in just 5 years. So that was really phenomenal. And you also talked about the need to strengthen capacity building. So again, I'm very happy that all of us have been able to attend this event. This was the last webinar in a series of 5. And I want to hand back to my colleague, Adudo, who will close the meeting. Adudo, if you've got anything to say. Thank you so much.
Thank you, Professor Mukabana. Oh, sorry. Thank you, Professor Mukabana. And I was about to share my screen to say thank you to all who have attended all our webinars from webinar 1 to webinar 5. Please fill in the, we have the feedback form in the chat box. So we would appreciate your feedback, and it will guide us in coming up with future webinars. As Professor Mukabana has said, there are so many topics that have arisen from this webinar that would be useful for to discuss in future webinars. So we thank you all, and really we appreciate all the speakers that have come through to speak to us and give us their insights. We truly appreciate sharing your knowledge, your experience with us, and we hope to see you again in another webinar. But till then, we hope that we continue efforts to not just what I got from this these webinar series is not just getting to zero malaria, but having healthy societies across Africa, not especially for young children, so everyone lives fulfilling lives. So thank you all for coming, and goodbye, and thank you.
Okay, goodbye.
Thank you very much, and goodbye. Remember to just fill in the form, everyone. Otherwise, thank you so much. Goodbye.